Hey, good day and good evening, everyone. It's so great that you are here with us today. Please let me know if you can hear me before we start. I will appreciate this information from you to know that everything is working fine. One more time, welcome, and I'm glad that you find the time for us today. I'm Sophie, and I'm your host. Welcome to IVF Webinars by Egg Donation Friends. We are here to be your helping hand along the IVF journey. That's why we meet here every week. So we have done over 60 IVF webinars so far, and it's our 61st this week. No matter if you are here with us for the first time or join us weekly, feel free to use this huge source of knowledge, and all our IVF webinars can be found on our website eggdonationfriends.com/IVF-webinars. IVF webinars are brought to you with the help of our partners, Eiselspende, fertility clinics abroad, and Donor Conception Network. And we are here today to talk about and actually get a virtual look inside the Embryology Lab, complete guide on IVF lab techniques and procedures. And of course, there's no other option. And today, expert has to be the embryologist. And so let me welcome Laura Vanos from IVF Spain, who will present the topic. And her presentation will last for around 20 minutes. And later, we will have some questions from you guys. So type the questions in the chat section if you have any, and you can start even from now. Just before Laura will take over, one more thing. The webinar is being recorded, so the recording will be available on our website tomorrow, and you can rewatch, share it, anything you'd like to do with it. Okay, enough from me for now. Laura, are you ready?
I'm ready, yes.
Yes, welcome. Fingers crossed, and let's do this.
So good evening, everybody, and thank you for introducing the topic, Sophie. I'm going to start directly with the presentation. So just as a little brief summary, as you know, when a patient goes through an IVF journey, the process consists in a number of steps. So first of all, patients will go through an ovarian stimulation in which they will have to take medication for several days. This process will culminate in an egg retrieval where the eggs will be collected. And finally, these eggs will be fertilized with the sperm cells. The resulting embryos will be left in observation for up to 5 days. It can also be less, depending on the situation of the patient. And the embryos which have nice quality will be transferred or cryopreserved. So this would be a little summary of the whole process. So we're going to start speaking about some techniques that are used in the embryology laboratory. Well, it's called a complete guide, but this would be impossible in an hour. So we're just going to make a little summary. At the first step, we could say that the first techniques that are used in the laboratory occur the day of the egg retrieval. So on one hand, when we retrieve the eggs, the first thing that we will do is to remove the cells that surround the eggs to see if the eggs are mature and if they are viable to be fertilized. But eggs are always limited in number. So basically, no such thing as a technique to select the eggs exists because all the viable embryos, all the viable eggs, if they are mature, will be fertilized. On the contrary, every sperm sample has millions and millions of sperm cells. And in the end, we'll only need a few. So for this reason, several sperm selection techniques have been developed in the latest years to try to find the best way to select the best sperm cells in the sample and to use these best sperm cells to fertilize the eggs. So usual techniques which we use in the laboratory every day, which are used in every laboratory and which are almost mandatory when you're processing a sperm sample, are density gradients and swim-up technique. What we do when we perform density gradients basically is taking the sperm sample, putting it on top of 2 or 3 layers of a media with different densities. Then this tube we place in the centrifuge. And what will happen during this centrifugation is that the sperm cells will separate from the other components of the sperm sample. So once we have isolated the sperm cells in the bottom of the tube, after we have washed this, what we will do is we will place some media on top of it. And the fastest and strongest and most alive sperm cells will be able to climb up this media, so they will be able to swim up. This is why the technique is called swim up, until the upper layer of the media. So after some time, we will remove an aliquot of the upper layer of the media. And this aliquot is the one that we will use to fertilize. If we're going to use ICSI, we will put it under a microscope. We'll look at the selection of sperm cells and we will choose the ones which look best. And if we're going to inseminate the eggs through IVF, we will just use this aliquot, maybe just dilute it a little bit. There are some patients who have some more specific problems that need to be addressed. And for these cases, there are techniques that are a little bit more specific. So, for example, there are some patients who have a high rate of apoptotic cells among the sample. One technique that can be used to overcome this problem is MAX. MAX stands for magnetic activated cell sorting. And basically what happens is that apoptotic cells are cells which have started the process of dying. So they move, they are alive, but they will be dead in some time. And you do not want to fertilize the eggs with these sperm cells. So with MAX, you could remove these sperm cells from the sample, because a very early sign of apoptosis is, well, the extrusion in the membrane of phosphatidylserine, which is a lipid. And this lipid will bind to a molecule called annexin 5. So basically, in this way, you will be able to separate the bad sperm cells from the good sperm cells. In any case, another technique that we can use to overcome some molecular problems, so to extra select the sperm cells, looking at some molecular characteristics, is PGT or sperm slow, which is basically the same principle, these two techniques. They are based on the fact that mature sperm cells will be able to bind to hyaluronic acid. So the technique consists in having an ICSI dish which is coated with hyaluronic acid. Mature sperm cells will be able to bind to this hyaluronic acid, whereas the sperm cells which have not undergone this maturation process, this molecular process, will be moving around freely. So it will give us a hint to distinguish these two kinds of cells, and it will help us select the best sperm cell for fertilization in the laboratory. Another extra technique which is possible to use for cases of sperm cells which have morphology problems is IMSI. IMSI is the name we give basically to using a very big microscope to select the sperm cells. So basically, you look at the sperm cells with a really big magnification. The sperm cell is more than 6,000 times amplified, whereas in a normal microscope, you would amplify it 200 or 400 times. And this way, the theory says you would be able to select sperm cells which have less back walls, which have a best morphology. So these are a little bit main sperm selection techniques that we could refer to. On the other hand, something else that might be helpful to know for some patients is that there are alternative sperm sources to the main source, which is obviously ejaculation. So for some patients, it might be preferable or necessary to use alternative sources. These alternative sources are the testicles and the epididymis. Sperm cells are produced in the testicles in a process that lasts around 2.5 months, 3 months. And these sperm cells then later mature in the epididymis. We can extract sperm cells from there directly by aspiration with a needle or by a little surgery. And this is indicated in case of patients, for example, who have undergone vasectomies for obvious reasons. There are some patients which might have difficulties collecting the sperm sample. There are some genetic mutations. For example, very famous one would be the one related to cystic fibrosis, which leads to the absence of vas deferens. So these are the tubes that expel the sperm cells from the body. And there are also some cases in which the quality of the sperm in the testicles seems to be better than the quality of the sperm cells in the ejaculation. So this seems to indicate that there are some cases in which sperm is damaged during storage or during maturation, and we can find sperm of better quality with less DNA fragmentation in the testicles. In any case, once that we have the mature eggs and once that we have selected the sperm cells, the next step is fertilization. So fertilization can happen by either one of two main techniques. It can happen through ICSI. ICSI stands for intracytoplasmatic sperm injection. And through this technique, what we will do is we'll directly microinject the sperm cell into the egg under a microscope with two micropipettes. One is holding the egg and the other one injects the sperm into the egg. The other technique is conventional insemination. In this technique, you have some droplets of media, and this media basically is your aliquot with sperm cells. You place the egg in these droplets, and the sperm cells will compete to naturally fertilize the eggs. So pros and cons of these two techniques. We all like IVF because it's more natural. So intuitively, it seems less invasive, let's say. Problem is, IVF has more risks because you're not really making sure the sperm cell reaches the place that it should reach. So it can happen that the next day you find there's a failure of fertilization. So basically, none of the eggs fertilized. And usually there's also a higher rate of abnormal fertilization. So for example, there's a higher rate of embryos which have 3 pronuclei instead of 2 pronuclei. So you might miss out on some viable eggs. So the embryologist will decide which of the two techniques to use, depending on the egg quality, depending on the sperm quality, and depending on the previous history of the patient. So in this section about fertilization, we have added this slide about artificial oocyte activation. Artificial oocyte activation is starting to be used in the latest years in patients which have had recurrent fertilization failure. For this particular case, we speak of recurrent fertilization failure in case of patients who are having less than 1/3 of their mature eggs being fertilized. This is not always due to a failure in oocyte activations, but sometimes it is. When you microinject a sperm cell into an egg, or when the sperm cell penetrates on its own into an egg, a series of molecular reactions are triggered. So it all starts with an oscillation of calcium ion, and this triggers a series of reactions which eventually lead to the fertilization. So this pathway is the one that seems to be blocked for these patients. We have had very good results with artificial oocyte activation for some of these patients. There is more than one way to provoke this artificial activation, but in particular, we are using calcium ionophore, and we've had very good results. It's a very simple protocol. You basically just have to culture embryos in droplets of calcium ionophore-rich media for 15 or 10 minutes after ICSI. Of course, you don't want to randomly use this technique if it's not necessary. What we sometimes do is we apply this media in all of the eggs if the patient has had cases of complete fertilization failure. And if it's just a low fertilization rate, we consider applying it only in half of the eggs to see if this is really helping the case. So we have spoken about fertilization. Now we're going to start speaking about embryo development. The day after fertilization, the embryos, if they have fertilized properly, they should look like the first picture on this slide. You can see that the egg has two bubbles. These bubbles are called pronuclei. It means that the egg is correctly fertilized. What will happen after this is that the embryo will start dividing. So on day 2, it will have around 4 cells. On day 3, it will have around 8 cells. Then the embryo will keep on dividing to 16 cells, 32 cells, 64 cells. But before it reaches that point, what will happen is that the borders of the cells will stop being visible. So the embryo will turn into sort of a ball, which is the morula stage. And we find embryos in this stage usually at day 4 of development. And what will happen next is that a little cavity will appear in this morula, and it will start to expand until we find the blastocyst. The blastocyst is a very defined structure of an embryo. You can see it on the last image of this slide. Basically, it's composed of 2 parts. There is a mass in the middle of the embryo. This is called the inner cell mass, and it will become the future baby. Then it is surrounded by a layer of cells. This is called the trophectoderm, and it will become the future placenta. At this point, the embryo usually has around 100, 300 cells. If you look at all of the pictures, you can also see there is a shell surrounding the embryo, and that it becomes thinner at the blastocyst stage. So more and more, we are tending to leave embryos in culture until day 5 of development. Why is this? Here we have an example of a patient who has 6 embryos. And again, we have chosen this example because it shows very well how embryo classification on day 3 of development is not always reliable. So if we look at embryos 2 and 5 in this picture, they look really nice for embryos on day 3. One has 8 cells, the other one has around 10 cells. Very symmetrical, stage-specific, very little fragmentation. They look really nice. But if we look at their equivalent on day 5, these embryos of the pool fail to become good quality blastocysts. However, if we look at embryos 1 and 4, at this static point, they do not look as promising as embryos 2 and 5. However, when we look at day 5, these were the embryos of the pool which actually became good quality blastocysts. So the point is that not because an embryo looks nice on day 3, does this mean that the embryo will become a blastocyst. It's normal that embryos do not become blastocysts. Not all eggs are programmed to do so, and it's like a natural selection process. So this is a little bit why we tend to leave embryos to day 5, because if you always transfer embryos on day 3 and you're not becoming pregnant, you might be wasting your time because maybe they're not even able to reach the blastocyst state. And this brings a little bit to the next point. And it's the fact that quantity is not the same as quality. So I will repeat this. Some patients have many eggs. However, very few of them turn into blastocysts, and these blastocysts may not be of the best quality. Whereas other patients may have less eggs, and however, most of their eggs will turn into good quality blastocysts. So it's not because you have more and more eggs necessarily that you have a better outcome. The quantity is way more important than the quality. So nowadays we have a very powerful tool to evaluate embryo development. This is called time-lapse incubators. Time-lapse incubators basically have a camera inside that take pictures of the embryos every 5 minutes. And this allows us to have a continuous recording of the embryos. In these incubators, every patient has an individual chamber. And since we can look at the embryos in a computer, we do not need to open the lid, take the embryo out, place it under the microscope. And and we do not need to disturb its stable culture conditions, because embryos, of course, have a special temperature, a special oxygen concentration, a special CO2 concentration, so we do not need to disturb them to do this. In addition, we can also get more information about the embryo, because we look at the embryo at a more dynamic way. We can make a morphokinetic analysis of the embryo, and we can study if the embryo has direct cleavages, irregular divisions, if the cell cycles are synchronical, how much the cell cycles last. And this information we can use to predict the implantation potential of the embryo, and to select the best embryo for transfer. So we get a lot more information. Another way we have to select which embryo to transfer comes after the embryo development. So PGT, pre-implantation genetic testing, is based on the fact that not all of the embryos will be genetically normal. So some embryos have genetic errors. What we do in the laboratory when the embryo reaches the blastocyst stage, what we can do is to remove a few cells from the trophectoderm. We extract the genetic material from these cells, we amplify it, and we sequence it. And this way we're able to know if the embryo has the correct number of chromosomes. So why do we do this? What would happen if you would transfer an abnormal embryo? Abnormal embryos, in most cases, do not implant. If they do implant, they mostly will lead to a miscarriage, and in a few percentage of cases, it could lead to a viable pregnancy of a baby which would be carrying a disease. So when you perform PGT and you make sure you only transfer the genetically normal embryos, you increase the implantation rate per transfer, and you save time up to pregnancy. One thing that is important to know is that the percentage of abnormal embryos is linked to maternal age. So the older you are, the more likely it is that a higher percentage of your embryos will be genetically abnormal. So especially in these cases, this technique would be recommended for you. So next, when we already have decided which embryo we want to transfer, there are also some techniques that have been studied that are starting to be applied to try to increase the implantation rate of these particular embryos. So we talked before about the shell that the embryos have around them. Embryos are like chicken eggs. They have this shell around them, and when the time comes, they break the shell and they come out to implant. They can only implant when they have broken this shell, and this happens at the blastocyst stage around day 5 or day 6 of embryo development. So when we transfer an embryo on day 2, on day 3, on day 4, the embryo will be in the uterus waiting, growing, until finally it reaches this point when it comes out and it can implant. In the laboratory, we can assist this process because this shell, we can make little breaks in it in the laboratory so that it will be easier for the embryo to come out. And when is this indicated? We find little benefit in performing assisted hatching in fresh embryo transfers. Fresh embryos should be able to hatch naturally. Nowadays, it's not really, studies don't really point out to a benefit of doing this. However, there's a consensus that when you freeze an embryo and you later thaw it, the zona pellucida, so the shell, might be hardened, and the implantation potential increases when you perform assisted hatching before transferring the embryo. So especially for these frozen thawed embryos, it's a very good idea to perform assisted hatching. There are different ways to do this hatching. There are chemical ways, there are mechanical ways. We particularly like to do it with a little laser beam. It's very easy to control and very safe for the embryos. So speaking about embryo implantation, to understand the process a little bit better, Like we said, when we transfer the blastocyst or the embryo, the first thing that will happen is that the embryo will hatch. It will come out of the shell. Then it will contact the wall of the uterus, the endometrium. Next, it will adhere to it. And finally, it will invade the endometrium. This process implies complex molecular interactions between the embryo and the endometrium. And there is a particular stage of the endometrium in which it is capable to performing these interactions. This stage is called the implantation window. And there are some theories that believe that the reason why some embryos do not implant is because the hatching of the embryo is not synchronized with the implantation window. So the point at which the embryo is receptive, ready to accept the embryo. So this is a reason why some women perform endometrial biopsies to check when exactly their implantation window is. So finally, I'm just going to speak about one more technique, which is related to embryo transfer. Embryos are always transferred with some culture media, and EmbryoGlue is basically a media which is rich in hyaluronic acid. So this makes the media a little bit more viscous, and the idea is that it will help the embryo stick to the endometrium. Hyaluronic acid is a molecule that is present in the extracellular matrix of most cells in the body. It's a natural component. It sometimes helps cells interact between each other. And some studies state that hyaluronic acid concentration increases a lot before implantation, and when the embryo has already implanted, it decreases. So it does make some scientific sense to think that this media could somehow slightly improve the adherence of the embryo to the endometrium. So thank you very much for your attention. I expect maybe you will have some questions about these techniques, or maybe about some other techniques, and we will be happy to answer them.
Thank you, Laura, for your presentation. Of course, we have already some questions waiting, so we will take the questions right away. But of course, if anybody has any questions, please type those questions in the chat section, and we will be then answering the questions one by one. Okay, so we will now start with the first one. Are there lab techniques, excluding ICSI, that can help with fertilization? I had complete fertilization failure in IVF this month.
So this would be the kind of patient for which we could consider to apply calcium ionophore. We would need to know a little bit more about your case. So, for example, how the sperm sample is, because we've had some patients which had extreme bad sperm samples where nothing was moving. And I remember a patient in this situation when we retrieved sperm cells from the testicles through a testicular sperm extraction. We actually managed to have a higher fertilization rate, and the patient is pregnant and they had a baby. So we would need to know your specific case, and maybe it would also be a patient candidate for calcium ionophore treatment. Yes.
Thank you a lot for the question and the answer as well. We will then take a look for the next question. Do you prefer one-step media or sequential media?
I don't think it makes a very big difference if the media you're using is good. If they have tested this media, if it's marked, if it has been tested for lung culture, it should have sufficient nutrients to hold for the 6 days. So I think if the culture media is good, I don't think it will make a big difference as far as I know.
And thank you for your answer to this question as well. Next question will be this one. Can we really trust PGT-A? What about mosaicism?
This is a good question regarding the mosaicism. For example, sometimes we have results in patients of embryos who are normal, and other embryos are clearly abnormal. And we also have one result of PGS usage, which is mosaic. We have found cells, different cells in the embryo. But these embryos, depending on which chromosomes are affected, the mosaic embryos can be transferred, at least in our clinic. If the patient decides to transfer mosaic embryos, he's able to transfer them depending on which chromosomes are affected. And it is true that in a small percentage of cases, it could be that the placenta is not representative of the fetus. But the same happens, I think, with a later screening. So it's a very small percentage of cases, and in cases where PGS is indicated, it's more important to perform the PGS, I think, than to look at this little percentage.
And thank you for explaining this to us. The next question, which we will take and look closer, will be this one. What is your practice of using media in time-lapse? Use media up to D5 without any change, or do you prefer to change media on D3, for example, even though it's single-step media?
Well, the thing is, we have seen that we have very good results with the single-step media, very good results. If you use sequential media, you need to take the embryos out, change the dish, so change the embryos from dish to dish. This takes some time, so it's a little bit of extra manipulation. So you would really need to make sure that it's worth it, that there is an added value in changing the media. I believe it's my experience that single-step media, which is good media, will give good results. I'm skeptic that sequential media will improve greatly the results unless that particular media is very good. I think there's a difference between one media and another media. But as far as I know, I don't think there's a big difference between single-step media and sequential media.
And thank you for the question and your answer, of course. Now we will take a question. I don't know if we can answer this directly, but take a look. I'm going to IVF Spain for IVF with PGS in October. Is it possible to have a biopsy for implantation window ahead of frozen transfer schedule for end of November?
So we're now in August, and you're going to do a cycle in October. Really, I would not dare answer this question because it would be more the doctor organizing, because you have to follow a certain medication plan to perform the biopsy, also a medication plan for the stimulation and the PGS and everything. So I think it's more a question for the doctor to see how much it lasts to do all this endometrial preparation. So I think we should leave this question to make it for the doctor later on. I think all the questions will be forwarded to the team, so you might get an answer.
Yes, of course. All the questions from today are forwarded to IVF Spain. So yeah, no problem at all. You will be linked all together. So you will also have the direct information. We will then take a follow-up question to the first one. Follow-up to my first question regarding the use of alternate lab techniques to ICSI. I have had 3 fails use and now a complete failed fertilization of eggs with ICSI this month. I used donor sperm, which was good, so sperm is not the issue. Great presentation. If you want to add anything on that?
Well, actually, yeah, it could be a failure of egg activation, and this is not always due to the sperm, so it could be due to the eggs. So calcium ionophore could be an alternative. Yeah, it can also be due to bad egg quality, could be. But this is right now what I can think of. Failure of egg activation due to that this could be the only thing that could maybe solve it, the calcium ionophore, or otherwise that the egg quality is so bad that it's preventing the fertilization, could also. Or, no, but it was through ICSI, so yeah.
Okay, thank you. And we will then jump to the next one. What's your opinion, I think, on group culture and single embryo culture methods?
Group culture. So I guess what you mean by this is that the wells in the dish might be connected. So the embryos in the dish might be sharing the media, or the wells in the dish might be separated, so the embryos might not be sharing the media. I think when these dishes have so much media, at least the ones that we're using, that I think there are plenty of nutritions for the embryo, way enough. And the molecules the embryos might produce that they are throwing away, let's say, are quite diluted. So also looking at the results of the good results, I'm skeptic that it's having a bad influence on the embryos. But I think there are many studies about this, and it's definitely worth giving it a look into it. Yeah, it's an interesting idea.
Thank you a lot for the answer and, of course, for the question. We will take the next one. In one of our last IVF, we tried our Pixie.
I guess
The
Pixie.
spermiogram of my husband was 17 million per milliliter. After the binding to hyaluron, they didn't find a single sperm to use for ICSI. Does this mean my husband's sperm are all immature, and what test could we do to find out?
Wow, it's amazing that out of 70 million per milliliter, no sperm cells could be found that were mature. There are some tests that you can perform to evaluate the molecular quality of the sperm cells. They will not exactly evaluate this, but you can perform, for example, apoptosis tests, DNA fragmentation tests. This might give you a little hint of how some additional information of what is going on molecularly inside of the cells, of the sperm cells. Also, when you have when you're at the moment of a cycle and you have to find sperm cells, you're running against a clock because you have to fertilize the eggs before a certain time. You cannot do it at 8 o'clock at night if the egg retrieval is early. The ICSI procedure has to be around 4 hours after the egg retrieval. So probably the laboratory will not have had time to inspect the 17 million sperm cells. They will have processed the sperm sample. They will have looked for several times. But maybe when you're not expecting this, because it's very unusual, you did not prepare with enough time in advance. So it could be that maybe even though it's difficult, with more time in advance knowing this, it's possible to find some sperm cell which is mature. One way you could try, if this problem is so severe, it might be that the sperm cell is not molecularly correct. It might also be that it has been damaged at some point of the process. So my guess is maybe you could also consider using an alternative source at some point of the process. But it's a very, very interesting case. I would need to give it a long thought to think what to do.
Thank you for this, for explaining this to us, of course. And we have also the following up question to the one which we have. So if you have any additional comments on that. Sorry, my question was not single step versus sequential media. Time-lapse use single step media, as we know. Some lab have a practice of changing media on day three, even in a time-lapse, because of the belief that endotoxins build up over time. What is your take on that?
Okay, so based on the results, I don't think there must be a lot of endotoxins floating around affecting the embryo development, because we have good results, and we're not changing the medium day 3. But my guess is, since there is so much media in the dish, these endotoxins are really diluted. But it's an interesting thought. I'm guessing there are lots of studies about this, and well, if it's the case, it could be an addition to the practice.
And thank you for giving us your answer to this question. As somebody is typing, I will let you know and show you some shout outs. Excellent presentation, Laura. Thank you. And one more nice presentation. Thank you. We have the next question, and the questions are coming up, so we will then take the next one. Just 1 second. Yes. In your opinion, what is the hardest step in embryology, I guess?
Well, when you're starting to learn a new technique, it seems like that technique is the hardest. But when some time has gone by, it actually seems like everything is easy. So actually, I would say the hardest job for an embryologist is talking to patients, because it's very difficult to put yourself in their place, and try to because, for example, doctors have a lot of experience talking with patients. They do so every day, so it's easier for them, but we are not really educated to do so. And patients, sometimes they have really devastating stories behind them, and the news that you're giving them is very sensitive. So I think for us, really, this is the hardest part of our job.
Yes, and thank you for the great question. And as well, I would like to ask another one. What is then the hardest step during the IVF from the patient perspective? Let's say the fertilization, or which step is the most critical one? What do you think from this perspective?
Yeah, so for example, fertilization is a very critical step, because, well, first it's your expectation about how many eggs you're going to retrieve, because maybe in the echography you were seeing a number of follicles, but not all of the follicles were mature. So there might be a change between the number of eggs that you were expecting and the number of eggs that are mature. Then the second cleavage point would be the fertilization. This is also where some eggs can fall out, especially in IVF. Once the embryos start to develop, usually embryos do not block at day 2. They do not block on day 3. The next critical point would be development from day 3 to day 5. This is the biggest, I think. This is the biggest point where you lose a lot of embryos, because, well, many embryos block from day 3 to day 5. They grow a lot. They go from 8 cells to hundreds of cells. It's like teenagers in their growth spurt. It requires a lot of energy. So it's also the point where many embryos fall off. So I think this is where this is the most critical point, where you can find the biggest decrease in numbers.
And thank you for this additional answer to the question. We will then move on to the next one. What do you think about Fertile Plus method for sperm sorting? I believe it's a centrifugation method.
To be completely honest, I'm not familiar with this method. I will search for it the moment this presentation finishes, but I don't have an opinion about it currently.
Of course, thank you. The next question then is this one. Some clinics use only donors that have children already. What difference does this make to the type of donor eggs produced?
So donors which have already had children, we would call donors with a proven fertility. So you know they are fertile, they are able to have babies. But just because of this, it does not mean that it will be a good donor, because it could be that she had the baby, imagine, 5 years ago, and her fertility decreased a lot since then. So not just because you have a donor with a proven fertility means that now she will be a good donor, not necessarily. And on the other hand, if you would only take donors that have had already babies, women nowadays in Spain are not having babies at their 18th, so you would lose a lot of good donors. And donors which might have the exact phenotypic looks as the patients, donors which might be very good donors. So donors with proven fertility are definitely very valuable. You have to look a little bit more into their history, but you would probably lose good donors if you would put this as a rule to only take on donors which have already had babies.
Yes, and thank you for the answer. The next question, which we will take a closer look, is this one. What's your opinion on group culture and single embryo?
I think we already came across a very similar question to this. It might be an idea, but I think it's also related to, it depends on which dish you're using and how much media is on that dish. So I think it's different to have, imagine, 5 embryos in 200 microliters of media than to have only 1 embryo in 20 microliters of media. Maybe you're culturing them in a single drop, but they still have less nutrients than if they were sharing. So I think it depends, but it might be a good idea, yeah.
Of course, thank you for your answer. And we have the next question ready. Can you tell us what kind of training and experience a good embryologist needs to have? Do they have a master's as a minimum?
I definitely think it's a help that they have had a theoretical specialization in assisted reproduction, because they need to understand what they are doing, all the decisions that they make, which consequences this can have for the embryo, what are epigenetics, what are endotoxins, I think you need to know what you're doing, and this will probably help. So I think it's important to have a theoretical background to know what you're doing, and also, of course, the practical background of having worked in a real clinic with real patients. Yeah.
Thank you, Laura, for explaining this to us as well. This will be also the final call for questions. So if anybody has any more questions, please prepare and type those questions in the chat section. And we will be soon slowly finishing. So if you have any questions, just feel free to let us know about it. The next one, we will now read and answer. In your opinion, are younger donors without children better than slightly older donors who have children? Does age of donor for a few years make a big difference to quality of eggs?
Depends on the age, So If we're talking about 24 and 22, then no, it would be better to take the donor who already has children, maybe, or in any case, it would make very little difference. If we're speaking maybe about 30 and 26, then I think it would be better to probably the 26-year-old donor would be better, at least in terms of euploidy and so on. But that said, some women at the age of 26 might have very low ovarian reserve, whereas others at 30 might have a super high ovarian reserve, and maybe they have better quality. So it's also something like intrinsic for every person, So these are little things that we can look at, and they will give us a hint. But it also really depends on the particular donor, her ovarian reserve, her AMH, and other things, her hormones and so on.
And huge thank you for the explanation. We have one more question for now. We have one more question, and this question is this one. I have 2 fertilized embryos. Would you go for blastocyst or transfer day 2 or 3?
To a certain extent, it's also a personal decision. Scientifically speaking, I think the best option would be blastocyst stage. Why? Because if the embryo does not reach the blastocyst stage in the laboratory, it will also not reach the blastocyst stage inside of you. And at least you will know. You will know if your embryos are able to reach the blastocyst stage or if they are not able to reach the blastocyst stage. And this information is sometimes important because it helps you know how to go on, right? Because we do see some cases of some patients who have done, lots of transfers on day 2, on day 3, and they never became pregnant. And maybe if they had left their embryos from out the start to day 5, they would have known that their embryos just didn't have enough quality to reach the blastocyst stage and thus a viable pregnancy. But some people prefer to transfer blindly. Some people say, psychologically, I just need, I do not want to see if it reaches the blastocyst stage or not, or I just want to transfer it blindly. We can respect that. But yeah, personally, I think it would be better to leave it to blastocyst stage because, like I say, if it does not reach the blastocyst stage in the laboratory, it will not reach the blastocyst stage inside of you.
And thank you for your professional opinion about this one. For now, we don't have any more questions. Somebody is typing, so we will just take a second to see if it will be a question or if it will be. Thank you. Great presentation, Laura.
Thank you.
Shout out one more great presentation. And thank you from our attendees. So we will be then slowly finishing our today IVF webinars. It was a huge pleasure to have you here, Laura, again.
Thank
And
you.
thank you for all the knowledge you gave us. Yes, thank you.
Thank you.
Thank you from our side today. And of course, as we said, everything will be forwarded to IVF Spain tomorrow. And I don't think that any questions left without answer, but if they will be also forwarded to IVF Spain tomorrow morning, the rewatch will be available on our website also tomorrow. You can, of course, watch it without any limitations. All the informations are available on our social media or website. Of course, following us on social media, you will be always up to date. And I can encourage you to stay tuned. Of course, thank you, Laura, one more time, and thank you, IVF Spain. Subscribe them also and follow their Instagram and Facebook. They have also great feed there. We will, of course, meet here next week, same time, same place, and it will be great pleasure to welcome you again. Huge thank you, Laura. Thank you for your time, everybody. Thank you for your presentation, Laura, and your answers to the questions. Have a great evening or day, wherever you are, and see you here back soon. Bye.